Welcome to Variations 4. This is the unit on shock. And in this video, we're just going to cover question 8. We're going to take some time here just to focus on the lab results in this video associated with shock. Now, this is shock in general. So some of these lab values are going to be more relevant for septic shock. Some of them might be more relevant for cardiogenic shock. But generally speaking, these are the lab values to keep in mind when someone mentions shock. And to a greater or lesser degree, you'll focus on one or the other depending on what type of shock it is. But we're going to lump them all together and just talk about lab values in general. We're going to look at table 69.3 from your Lewis textbook. So I'm just going to do a quick overview here. It really is up to you to read through. It's really up to you to read through these on your own and ensure that you have some understanding. A lot of this should be somewhat review and a little bit might be new. But again, what we're looking at here is table 69.3 from the 4th edition of your Lewis Medical Surgical textbook. And we're not going to look at every single one of these. And the ones that I mentioned are the ones you need to focus on, okay? So let's just start. I'm going to have to kind of increase this so you can see this better if it's on the overhead in the classroom. So let's just kind of start here. So the first one is arterial blood gases. And so, I mean, it really depends on what's going on. So in early shock, if your patient has the energy to hyperventilate, and it kind of makes sense that they would in early shock, because they're compensating for that decreased perfusion, decreased O2 nutrient delivery. But if they hyperventilate, they might be doing what with CO2? They might be getting rid of it, and that could be causing alkalosis. If this is in any way puzzling to you, you need to review Unit 1 on lights and pH balance. Now later on, as they get tired out, they might be hypoventilating, and they could be holding on to CO2. So that could cause respiratory acidosis. Okay, that's not mentioned here, but that's something else to consider. Another thought that is mentioned here is metabolic acidosis. This is very common with any of the shocks. Can you explain that? If you can't see all of this too, then you need to look at your own textbook. This isn't meant to be showing everything. I'm just doing a quick overview here, and you can kind of read all the details later in your own textbook. But the bottom line with this is what it's saying is that whole thing of decreased nutrients, decreased O2, cells go into anaerobic metabolism, lactic acids produced, and that is acidic, that's metabolic acidosis. If this whole thing is Greek to you, again, you need to review the pH section from Unit 1. Base deficit, don't worry about that one. Blood cultures totally makes sense, especially if we're talking about something like, which one of the shocks does blood culture make the most sense for? Well, it says it right here, septic shock. Okay, BUN, creatinine, and I don't know where GFR is in here, but a decrease in GFR and a decrease in GFR and an increase in BUN and creatinine, that should be totally intuitive to you by now, by this level. Whenever you've got decreased perfusion, your renal panel is going to look like that. Okay. The CK, we've talked about this in the cardiovascular units. Some bands of CK are specific to, cardiac muscle damage. So that might be causing an elevation, especially if it's cardiogenic, or there's damage to the heart from the shock itself. Of course, just general trauma to muscle in general, from maybe lack of oxygen, could also cause a rise in CK in general, even the non-cardiac MB band. Okay, and then the DIC screen. Now, we are going to talk about this again in a later question, but a little bit more, but let me elaborate a little bit more here just so we can get through these labs here. So disseminated intravascular coagulation is not well understood, but it is correlated, or maybe they've even gone as far as say it's caused by or comes up a lot with septic shock. You can come up with other shocks too and other conditions, but septic shock is really the classic connection, kind of segue to DIC, disseminated intravascular coagulation. What happens in DIC is that you have tons of thrombi forming throughout the body, and you can imagine what kind of issue that causes in itself in terms of clotting, in terms of emboli, in terms of cutting off of circulation, risks for PE, risks for stroke, risks for DVT, all that. But at the same time that these clots are forming, the body is using up all of its coagulation factors and platelets to form these emboli. And so they're all being used up. Now, if coagulation factors are being used up, then PTT and INR goes what? Up or down. If coagulation factors are being used up and therefore there's less of them in the body, is PTT or INR going up or down? It's going up because we're running out of coagulation factors. And so the bleeding risk is increased too. So this is what you call a paradox. Two things that are happening that you don't expect to happen at the same time, but they are with DIC. And that is, again, one, increased clots, and yet paradoxically, two, increased risk for bleeding. Very difficult to treat if it's bad enough. But now the lab results make perfect sense with DIC, all these here. So D-dimer's increased because D-dimer, remember, is a test that tells you if you've got clots in the body. So if D-dimer is increased, it means you've got clots in the body and the body is trying to break them down. D-dimer captures the clot degradation product of those clots trying to be broken down. Doesn't tell you where the clots are, just tells you you have them. So we've seen D-dimer in other units that when someone has a negative D-dimer, it means there's no clots in the body. But when it's increased, it means you got clots. So don't worry about fibrin split products, although looking at it, of course, it makes sense because fibrinogen and all that is part of clotting. So it kind of makes sense, but I don't really care if you know that one or not. Same with fibrinogen level. Fibrinogen is being used up. So again, I'm not really worried about that one. Platelet count definitely would be decreased. That should be obvious to you. And PTT and INR are prolonged or elevated in time. That should be clear. Same with thrombin time should be clear. So PT. Okay, moving off from that now into other lab values. So glucose makes sense to be increased early on as the body releases energy stores to try and get through the stress response. Liver is releasing glycogen. If no one intervenes to help out, eventually the body is going to run out of these glucose stores and then glucose will decrease. Lactic acid increased, we talked about that above, the product of anaerobic metabolism. Now, liver enzymes. Why do you think liver enzymes could be increased in any kind of shock? Well, remember, shock is decreased perfusion to the organs. So if the liver is one of the organs that's suffering from decreased perfusion, then it's going to have cellular damage and possibly cellular death, which causes the release of these liver enzymes. Potassium, of course, potassium could be increased if there's cell death. Potassium could also be increased if you've got acidosis. Remember, hydrogen moves into the cell, potassium moves out. So review unit 1 if you're not familiar with that. Of course, alternatively, potassium could be decreased because decreased perfusion means decreased circulation, which means aldosterone might be released in higher amounts. And aldosterone does what to potassium? It kicks it out of the body and holds on to sodium. And so potassium could be decreased for that reason. That's kind of an either or. I mean, a lot of these are like, you got to look at the patient context and the big picture. So they're either or on that one. RBC count, well, it really depends. Of course, easy to say could be decreased if there's hemorrhage, or increased if you've got something, for example, it's because they're just dehydrated, for example. Or hematocrit, for example, could be increased in some of these shocks that cause maldistribution because the water portions flow to tissues, leaving red blood cells behind in a relatively concentrated environment. Of course, they could be normal because maybe there's fluid resuscitation going on. What does that look like? So maybe they started out as being dehydrated, So hematocrit went up, but then now they're getting IV fluids, so now they're normal. So RBCs could be all, and hematocrit and hemoglobin could be all over the place. Just depends on what's going on with the patient. Same thing with sodium, as we talked about. Early on, it might be increased because of aldosterone. Later on, it could be normalized or even decreased because of increased IV solutions, maybe non-sodium solutions, D5W, for example. Troponin obviously would be decreased if you're talking about something like cardiogenic shock. And even if not cardiogenic shock, why would troponin be increased possibly? Again, troponin could be increased from any of the shocks because if the heart's suffering from lack of perfusion, there might be some tissue damage. Troponin's released. So specific gravity, don't worry about this fixed at 1.1. Don't worry, we don't need to apply that. But the increased one for sure makes sense. So we're talking about urine here. Someone's voided. You've taken a dipstick of it, and one of the measurements you can get is specific gravity on it to see how concentrated is it. So if they're in a dehydrated or hypovolemic state, the body's going to be trying to hold on to water. The kidneys, by the action of ADH and aldosterone, will be holding water in the body. That means less water going into the urine itself because the renal tubules reabsorb it, put it back in the body, and the urine is more concentrated with less water. Something that's more concentrated has more weight to it, more solutes, and that's why you see specific gravity increased in times of shock.